We are all aware of the King's classification for adolescent idiopathic scoliosis, the thoracic kind. And the key concept that emerged from this classification was the idea that you can do a selective fusion for these double curve patterns. And this actually lies at the heart of John Moore's legacy. The other revelation of this classification was for single curve patterns, where two kinds of thoracic scoliosis were identified. One was the long thoracic type, where the L4 was tilted into the curve, and the double thoracic kind, where the left shoulder was higher. Nowadays, we use the more comprehensive King's Lenke classification, which has all these 6 types, and the Lenke classification actually tells us the regions which need to be fused, but it does not make any specific recommendations for the upper instrumented vertebra or the lower instrumented vertebra. It does not take into consideration the clinical appearance and the skeletal maturity of the child, which has a considerable influence on selecting the fusion levels. And the bending X-ray assessment of the classification is somewhat arbitrary, especially the 25-degree rule, which leads to a lot of rule breakers. For example, a Lenke 3C curve treated with a selective thoracic fusion. And there is no inclusion of the King 4 variant, which is about 9% of thoracic scoliosis. So Dr. Lenke has added another modifier to his classification, which he calls the last touch vertebra, which can be helpful to identify the last instrumented level. This is defined as the most distal vertebra that is touched by the central sacral vertical line. A slight modification to this is the last substantially touched vertebra, and I find this more useful. This is the most distal vertebra whose pedicle is touched by the central sacral vertical line. The fourth modifier is the AR modifier, which Dr. Peter Newton's group itself described. The Lenke A1 curves are classified into 2 kinds, the left and the right. So if the L4 is tilted to the left side, like this Lenke A1 curve, it is called Lenke AL, which is similar to the King's 3 type, and the other in which the L4 is tilted to the right, which is similar to the King's 4 kind. So let's see how does this apply to selecting the LIV. So this is a Lenke 1A curve. You can see that on the left bending, it is tempting you that the lower instrumented vertebra could be higher, but notice where the L4 is. The L4 is tilted to the right side, and we have known since 1983 that fusing short on these kind of curves risks an add-on. So that's why the recommendation for a Lenke A1R curve or a King's 4 curve is the LIV, that is the last substantially touched vertebra to the central sacral line, which in this case is the L3, and that's why the fusion goes down to L3. For a Lenke 1AL curve, similarly, the last substantially touched vertebra is usually higher than a 1AR pattern, and in this curve type, it is L1, so that's why the fusion goes down to L1. This usually is the stable -1 vertebra. For the double thoracic pattern, the King 2A and 2B, the distal level of instrumentation, the recommendation remains the same as the Lenke 1A curve. The upper level changes. For the double curves, the C modifier curves, the 1C, 2C, 3C, and 4C, one needs to always ask a question, is selective thoracic fusion possible? And we need to consider 3 important aspects of the curve whenever making this decision. The first are the radiographic criteria defined as ratios. Essentially, this means that the thoracic curve should be at least 20% bigger than the lumbar curve. The thoracic apex should be 20% more translated than the lumbar curve. The lumbar curves generally are more flexible than the thoracic curves. Obviously, no thoracolumbar kyphosis. Assessing the rotations on X-ray is a little bit difficult. That's why one always has to look at the clinical appearance of the patient. If the scoliometer readings show that the lumbar prominence is bigger than the thoracic prominence, then whatever those radiographic parameters may show you, that's not a good candidate for doing a selective fusion. And lastly is the skeletal maturity, and we have known for a long time doing selective fusions for very immature kids can predispose them for an add-on, and sometimes these patients also, in addition to fusion, need to be braced. So how do you choose the LIV for selective thoracic fusion? The LIV is the stable vertebra. In this curve pattern, the stable vertebra is D12, which is the most bisected vertebra by the central sacral vertical line. If the disc is the one that is bisecting the CSVL, then you choose the stable vertebra plus 1. So in this case, the fusion has gone down to D12. And mind you, you have to correct the thoracic curve to a lesser degree, otherwise the lumbar curve won't compensate it, and there has to be some amount of tilt left in the D12. For non-selective fusion, essentially the debate is between L3 and L4 for the last instrumented vertebra. And the general rule is that the LIV should be the end vertebra for these kind of fusions. So if L3 is the end vertebra, go down to L3. If L4 is the end vertebra, go down to L4. However, sometimes the L3 is the end vertebra, but the L3 vertebra is not touched by the central sacral vertebral line. You can still stop at L3 provided that the L3 is within 3.5 centimeters of the midline. There are other ways to judge this, and different surgeons have different ways of judging it, like bending X-rays or traction X-rays. The fourth kind is where you have the L3 and L4 disc that is parallel, in which case you can measure the same cob angle from L3 as well as for L4. So here the recommendation is that you try to go to L4. Some surgeons would, in this curve pattern, still stop at L3 provided that you are getting at least 2 fixations or that the apex is a little higher. If the apex is lower, then it's better to go to L4 in patients who have L3, L4 disc parallel. So you can see this case, the 57-degree cob angle measured for the lumbar curve can be measured from both L3 and L4. It bends down to less than 23. On a general anesthesia prone X-ray, the L3 still is way off from the midline. So here the decision is made to go down to L4. How about the upper instrumented vertebra? Most importantly, the upper instrumented vertebra is chosen by these shoulder levels more than the T1 tilt or the proximal thoracic kyphosis. If the right shoulder is higher, then the fusion stops at T4 or T5. If the left shoulder is higher, then the fusion stops at T2. If it is level, it stops at around T3. But it depends on how much of main thoracic curve correction you are going to get. So for this example, this curve, the proximal thoracic curve bends to 23. This is another rule breaker. Lenke classification tells not to fuse that proximal thoracic curve, but notice that the left shoulder is higher. So you are going to take that into the fusion. So this fusion will stop at T2. This is another curve pattern. Proximal thoracic curve is 64 degrees. Shoulders are level. You are expecting a greater main thoracic curve correction. So if you don't include that curve, the left shoulder is going to get pushed up higher. For the lumbar curves and the thoracolumbar curves, it's pretty much the fusion from end vertebra to end vertebra, whether you go from the anterior approach or a posterior approach. Thank you very much.